So we will start. Good morning. Thank you all for joining. This is the same patient that we discussed last week. Last week we managed to resect a lesion in the cecum. And today I'm going to take you back in terms of, as the scope is withdrawing, what else did we see and what did we do? One thing is this is a longer video, and I kept the video segments long so that for those of you who want to learn about different aspects of resection and also how to close a large defect. And you will see a lot of details because I just purposefully left the segments long so that you could appreciate how to close a large EMR defect. So this is, for those who have not heard this case before, this is a patient in his 70s who was referred for EMR. He survived a tough problem, a diffuse large B-cell lymphoma that was diagnosed 10 years ago. He was treated by oncologists, including stem cell transplant. And in 2018, his PET scan was negative for any recurrence of lymphoma. He also has atrial fibrillation and ejection fraction of 52%, chronic kidney disease stage 4. And he had a PET scan positive for lighting up the duodenum. And the PET was followed up with an endoscopy, and that showed a large duodenal adenoma. And the surgeons felt that it is best to figure out whether he will be a candidate for surgery. Currently, he's going through the evaluation. At the same time, he underwent his first colonoscopy, and unfortunately, he was 70s. First colonoscopy, it's in 70s. It means that, you know, things have not happened at the appropriate time. And he was found to have polyps, and he was referred for a resection. So that's the story. And I want to thank my colleagues, Selvi, Roy, Sylvia, Sriram, for helping with this program. And I want to acknowledge the support of my mentor, John Storline, Mr. Charles Butt for the grant, Ms. Angela Deal for the illustration, and my institution, University of Texas MD Anderson Cancer Center, for supporting me to do this program. So we went through the story, and this is where we left last week, right? We did a large cecal polyp resection, and we closed the defect. And then I will show you after closing the defect what we did. So we are coming out just above the ileocecal valve, and we see this lesion. All right. Sylvia, any comments?
Well, I think that I would characterize this lesion as rather sessile. I was thinking first, is this a laterally spreading tumor? I think not, because the height of the lesion is higher than half of the diameter. So I think that's a sessile polyp, and I don't see any signs concerning signs of some mucosal invasion, like converging folds toward the lesion, expansion, irregularity. So I think that this is a benign lesion, a benign sessile polyp. And I would like to use, if possible, imaging, enhanced endoscopy to look at the surface detail to make sure that whether it's an adenomatous or serrated polyp.
Oh, thank you. What do you think is the size of this lesion?
I think about 1 centimeter at most.
Okay.
Usually I look at the circumference, and a quarter of the circumference would correspond to 2 centimeters. So in my opinion, this is less than a quarter of circumference. So that would be like one centimeter in size.
So the thing is, actually, this is this area, to be honest with you, when I was trying to find that large lesion that we saw last week in the pictures that were taken by the endoscopist, and we couldn't find, I examined this area multiple times. And to be honest with you, in my evaluation before I did the cecal resection, I did not see this lesion. But at the same time, I said, okay, I saw the lesion, let me just go and resect. So what I thought that was, I will take you through something else next, right? You see that it's going on the other side of the fold as well. And probably did not look, to be honest with you, big. And I have my colleague and friend, Aman Paul, who's actually in California, in Sacramento. He trained with us. Aman, what do you think? What would you do?
So I think the proximal end towards the cecum of the polyp, I don't think I got a very good look at it. My first thought is, to go further beyond into the cecum and pulling back slowly, retracting that fold using the cap. This is where I think the cap is very helpful to retract that fold to see how much is there. And is that, sometimes I find that the flat portion or so as between the two folds is sometimes the, bigger than what you see on the top of the fold, and it's more laterally spreading. This is like sort of the tail, what we see at the end. And sometimes there's a bigger head in between the two folds. So I like to see that a little bit better and see how much circumference is being involved in that area, because that's going to be more difficult to take out than what we see in the picture.
Yeah, I think it's a very important point that I want to share in this case. Polyps are not necessarily what you see is not what you get. To be honest with you, you will find this in this patient. And you don't want to think that, okay, it is a lesion that is on the fold. And like Aman commented and Sylvia commented, it's always good to look at the circumference. And I try to go up and down, actually. When I was trying to look for that original lesion on the cecum, I spent about 10 minutes trying to clear this area, examine multiple times. And initially, I didn't really see this, probably because the fold was on, the polyp was on the appendiceal side of the fold. But when I came back, this is what I saw. And when you see this lesion, you should not, one thing you shouldn't do is take a hot snare and cut, or take a cold snare and cut. You want to make sure that you can define the true extent of the polyp on the other side of the fold as well. That is really very important to do, and something to keep in mind. Otherwise, what you think is you cut the polyp, especially if you do a cold snare, it will bleed. And then you feel that, okay, you got the polyp out. You may not take a photograph to document whether your edges are clean, and you move on. And what happens is the patient will have recurrence of polyp. And if the polyp is a little bit nastier, these are the polyps that actually could go on to develop cancer. I remember listening to Sylvia's talk about cancer after colonoscopy. How do you describe that cancer that comes after when you resect a polyp and it comes back? What's the term you give, Sylvia, for that?
It's a post-colonoscopy cancer due to incomplete resection.
Right, right.
Or an interval colon cancer, I think.
Right.
Yes, that's the difference. I mean, interval means that we advise the patient to return for colonoscopy within a certain interval. So it should be an interval, and this didn't happen. So it's an interval cancer. In general, every cancer which occurs after a colonoscopy which was negative for cancer would be a post-colonoscopy cancer. And of course, there are algorithms to identify the most likely explanation. We can't say with certainty that they are due to missed lesions or biologic factors, but using this algorithm, which has been shown in the WIO consensus statement paper, we can say whether the lesion is the post-colonoscopy cancer is likely due to missed lesion or to incompletely resected or to non-compliance with surveillance intervals.
Right. Thank you. All right. So then we decided to go in and inject, and let me show you what we did. So whenever I try to inject, I try to go to the proximal side, especially if there's a fold if the polyp is in a fold, and try to inject on the proximal most portion. And as you can see here, we got the needle on the proximal side, and we are injecting saline with a little bit of methylene blue, and I didn't put any epinephrine. And once I get one spot, I do not let it go. And I want to inject as much as possible to avoid the risk of multiple punctures and losing the fluid or escape of the fluid through the multiple holes. So although we got a good injection, I think in the first injection, we probably injected about 10 cc. And whenever you're injecting fluid into a polyp that has gone over the fold into the valley, you can inject 20, 30 cc's to fill up the valley and make the polyp come up. That's what we are trying to do here. So this is the second injection. As you can see, I'm trying to get this polyp lift up. And these types of polyps, I want the polyp to come en face to make my resection a little bit easier. So I thought that I needed to do a little more injection. So basically we injected about 3 sites, as you can see. That is something different from the ESD. When people do ESD, they try to do small injections around the periphery. But when doing an EMR, you want to get as much as possible with one injection, or maybe a couple of injections in the initial setup to get into a better position. All right. Any comments on this now, Sylvia? You see this lesion a little bit different now?
I think that it's a very nice illustration of the effect of submucosal injection on the appearance of this lesion, which is not anymore the sessile polyp I have seen in the very beginning, the small sessile polyp. We can now detect a laterally spreading tumor, in my opinion, of granular homogeneous subtype. It's a benign lesion. Again, I don't see any signs of submucosal invasion, but it's a very good illustration that we can't characterize and classify the lesion only after good insufflation and submucosal injection, which stretches the lesion, lifts and stretches the lesion. It's a kind of umbrella effect, we call it. So only if you open the umbrella, you can see the nice model on it. So that's the same with this lesion.
I like that. I like that description. Yeah.
That's good for trainees to remember,
right.
The umbrella sign.
Right. So one thing is a couple of learning points that I want to stress. when you see a polyp on a fold, don't jump and snare it. You know, it may look tempting to get your cold snare or hot snare, and you want to do that. Don't do that. You want to ask yourself, okay, is there something hiding on the proximal side of that fold? If you look at it, what we originally saw on the top of the fold is probably about 1/5 of the size, total size. You know, there is another 3/4 or 4/5 size hiding in the valley or the intercostal area proximal to that. Salvi, any comments?
No, sir, I agree with everything that's been said. I definitely can be fooled at first glance at polyps. So I think the time that we all spend examining the polyp up front, getting good pictures, making sure that, you know, your assistant also understands where the borders of the polyp are. The time that you spend up front, I think, will save you a lot of time afterwards, during and after the resection.
Right.
May I make a short comment, Professor Raju?
Please.
I think that knowing that the lesion is most likely a laterally spreading tumor, granular homogeneous, helps to decide the best resection strategy, because we know these lesions have the lowest risk. They are the most common lesions. About 1/3 of all LSTs are granular homogeneous subtype, but they have the lowest risk of submucosal invasion, less than 1%. So we can resect them by piecemeal EMR if unblocked resection is not possible. So this is an additional information we get from accurate evaluation assessment.
Right, right. Okay, so how are you going to cut this polyp? Salvi, what is your snare that you will pick up, and what are your settings? I want to ask each one of you, Salvi, Aman, Sylvia, and I think Joseph is here. Joseph can join in.
So Raju, I made the comment last week about, you know, your voice is inside my head when I'm doing colonoscopy and EMR. So your voice in my head tells me when I see this lesion that it's a 10mm hot snare that I use. And my electrosurgery unit settings are EndoCut Q313. I may end up using a 15mm. I think it would just depend on what it looked like, but I probably wouldn't go any larger than a 15mm snare. And one thing that I do, just because I'm not, you know, an expert like Sylvia in terms of looking at the lesion and kind of making my best guess as to the size of the lesion, I'll open the snare. Usually it's a 10mm, as I said, and hold it against the lesion and kind of use that, take a picture and use that as a ruler. So yeah, I'll let the other panelists speak. Thank you.
Sriram. Joseph.
Joseph agrees in the chat.
Okay.
His mic is not on, it's not working. Sorry, Joseph.
Aman.
So, you know, I use Cook snare. I tried Boston scientific snares, which are a little bit more stiff. But for some reason, you know, I'm not sure why, I cannot explain, but I like the Cook Echo snare. I think it's a 13 or I think maybe around 15mm snare. And my goal is generally, you know, to capture as much as I can with especially in these kind of polyps, so that I can limit the number of pieces that I'm removing. And because the snare is, you know, 15mm, I know that I'm not gonna be picking up like a 3cm or 2.5 centimeter in one time, probably. That's likely, I think. And then what I try to do on the cutting settings is, you know, generally anywhere between 25 to 30 watts. And I keep the effect around 2 or 3, mostly, 2. And I use pure cutting current on the yellow pedal instead of the blue, because I find the edges, in my experience, come out a little bit smoother, which are easier to clip afterward if I use minimum coagulation.
Right. Sriram.
Sriram said he had no mic, Raju.
Okay, sorry about that. So one thing is I want to share with you is for those of you who are starting EMR, I think it's in the right colon or especially in the cecum. My recommendation is until you get a feel for yourself and you develop some confidence, it's a good idea to start with a 10 millimeter snare. It may require a few more cuts, but I think you will be a little more safer because you grasp for smaller areas. When you grasp smaller areas, you're less likely to grasp the muscle, so less likely for a deeper injury. And so that way you avoid the risk of perforation. And also when you avoid a deeper injury, you also avoid deeper blood vessels. So you can run a much smoother operation. So that's one thing I would suggest. And the second thing is you want to keep your snare plane parallel to the wall always. That's one thing you want to keep in mind. So in this case, I used a 15 millimeter snare. And as you can see, I was trying to grasp bigger specimens, but I kept losing the specimen. So then I went back and cut a smaller specimen. So once we cut the smaller specimen, he actually bled. And as you can see here, this is the bleeding that you will see. So I didn't waste any time to control this bleeding because now my electrosurgery settings that I use in my Irby machine, on the left side is Endocut Q313. And on the right side, I changed my forced coagulation to soft coagulation, effect 4, 80 watts. So all I have to do is basically change, get my snare tip smaller and just use my blue pedal and coagulate. And it works very well for smaller vessels. But if it is a brisk bleed or a bigger vessel, the snare tip soft coagulation may not be effective, in which case you may have to get either a clip or a hemostatic forceps. So then we moved on and to cut the remaining portion. Basically, this large polyp, as you can see here, we cut it for two segments. And then this is the third segment. And as you can see here, I'm trying to suction a little bit and try to get as much of the remaining polyp in the remaining cut. And it is a quick cut. So again, there was some bleeding there. And we use the snare tip soft coagulation. Right. One thing I want to mention to everybody is you can see that the operating field is quite stable. You don't have a lot of respiratory movement. That is because all the EMRs that we do, we ask the anesthesiologist to put the patient under general anesthesia with intubation and paralyzed with a tidal volumes small enough so that you don't have large swings of the colon. And that is important, otherwise you will be struggling to hit a moving target. So as I'm coming back, I'm actually trying to see if there are any other vessels that I need to coagulate. And I'm also examining the edge of the lesion as I'm coming back. And I can see that there is a lesion a little bit on this side that it's still left, a little bit of tissue that is left. And I'm looking at the right edge. That's the one small area. Question is, can we just cauterize? I usually try to remove anything that I see. So basically now we're examining both sides, and the rest of the edge looks good. So this area that is on the left side, that's on the right side, if you can try and use a snare, probably you have to use a small snare to cut it. Or you can use a hot biopsy forceps. There are different ways to cut it. Or you can just use a cold biopsy and rip it off. But I try to use a hot biopsy so that I can actually remove that. And I want to show you what we do. So when we use a hot biopsy, you want to change your settings. If you're using Irby machine from Endocut Q to Endocut I, and I put effect 1, that means it's almost a pure cut. There's no coagulation with effect 1. And then duration, I try to increase it to at least 3 or 4. And then the interval, I just keep it 1 so that, when I pull it out, it will cut clean. So one thing is you hold, try to grasp the area and pull back and make sure that your metal doesn't spread the current to a different area. So that's all. You want to, let's look at it, because this is the same technique that you use when you have a polyp that is tethered to the wall. Pull back and tap on the yellow pedal. Just a one tap and another tap if it's needed, so that it comes out clean. So as part of my practice, I think as part of my own protocol, I've been doing the same thing so that we can at least learn something. And for the last 10 years, I've been doing APC of the edge as a part of a routine. And the settings that we use is a flow of 0.8 liters. I try to use 35 watts and forced instead of pulse or precise. You can use pulse or precise. You just have to get used to one and then try to get better with that one technique, as long as it gives you good results. So, and then I always use a forward jet APC. So what are the alternatives? The alternatives are based on the literature. You can use snare tip soft coagulation. And that also has been shown to be effective in placebo-controlled studies. And there is no study comparing APC with snare tip soft coagulation. But to be honest with you, I don't think there will be much of a difference. So if you say, okay, I want to save additional cost, I think snare tip soft coagulation is not a bad idea. But one thing is I try, this I find it a little bit easier. That's why I try to use this. And I want to see a brown effect at the edge. And for those of you, if you can't really have a stable field and the field is moving up and down, then one option is to change from force to a precise mode. The precise mode would still deliver the cautery effect, even if your catheter is varying in distance by a few millimeters. So that is one of the advantages of using a precise method. So if you look at it, this is a large defect, right? And let me ask the group, how are they going to close and what techniques do they use? So why don't I start with Aman and then Sylvia, Selvi. If Sriram's mic is working, Sriram can comment. So when you have a large defect like this, how do you close, and what instruments do you use, and how do you go about it?
So it's a challenge, honestly speaking. The size of this defect. First debate in my head is it something we can close, or is it something that we have to leave it open, or is it something that at only in particular edges should I put the clip, which seem to be more prone for post-polypectomy bleeding. So, it is a little difficult to decide sometimes. But then sometimes I say, okay, let's start from maybe one edge, and then if it continues, I'll completely close the defect. So that planning sometimes is crystal clear, and sometimes, honestly speaking, is not completely clear when I start. But I always want to start from an edge, and generally, it's the right to left edge that I go, just because I think the right edge seems like it's the most difficult. And then as I'm coming towards the left edge, it becomes easier and easier. So, and the middle of the defect is where it's probably going to be very challenged. But I think sometimes what happens is as we are retracting, we put initial 2 or 3 clips, the size of the defect starts becoming smaller in the center. And so I typically use for these kind of defects, the widest clip available currently on the market is I think the Cook clip, to my knowledge. So that's at least what's available in my facility. So that's what I use. I'm sort of excited for the Boston Scientific coming up with a new clip, which is not currently available at our facility, but I heard that they are coming up with a 17 millimeter endo clip.
Right, thank you. Sylvia.
I think I would follow a similar rationale, but in my own experience, such a large defect is difficult to close. I would make sure there are no visible vessels, nothing which can be treated in the resection surface, and I would let it open if not possible to. So I think it's a large defect. It's difficult to close, right, in my experience.
Right. Are you using any of the chemicals to put it on the defect that I've seen that in Europe being using to cut down the bleeding?
But only for studies or not as a routine practice.
Okay. All right. Salvi.
I would echo what Aman, Paul, and Sylvia said, Raju. I mean, I think this will be a challenge, but I think it's, it's the right colon. He's an older gentleman. I think he's on aspirin or has AFib, so some kind of anticoagulation may be happening. I think we should I would feel better if I at least tried to close it. Whether it would be a perfect closure or not, that's probably less likely. And I would echo what Aman said about once you start closing a defect, the defect gets smaller and it becomes a lot more manageable. I had shared a case earlier during one of the Sunday Zoom sessions where it honestly looked like, again, I think it was an ascending colon lesion, looked like there was no way that it was going to close. But once I started kind of putting some clips on, some of the lesion kind of folded up together and made it a lot more manageable. Right. The last thing I'll say is the MicroTech clip is also helpful sometimes. So you may need to use a variety of different clips. It's kind of real-time decision-making as you're closing up the defect, and use everything at your disposal. Thank you.
Joseph.
Yeah, Joseph it doesn't have that mic, but he says he loves the MicroTech Sure Clip 16 millimeter smiley face. So he likes that one. Right. Yeah.
Okay. All right. Okay. So this is what we did. I didn't. That
looks like the MicroTech clip.
Close. So I thought that, okay, we'll start with the one end. I try to start on the left side because when you look at it, access to the left side, when you have your scope channel in the right lower bottom is much easier. It's much easier. You don't have to, you go in. So I want to stop here and I want to share some thoughts. When you have a large defect and this large defect, you cannot close with any clip, even with the Microtech clip or even with the Boston Scientific clip. If you're trying to go from one edge to the one mucosal edge to the other mucosal edge, it's almost impossible to do that. So what I found was, I say to myself, I will put clips into the submucosa, not worry about getting mucosa to mucosa edge. And then as I put the clips, I leave gap in between the clips. Yeah, so that once the defect becomes smaller by this first set of clips, then I can use the next set of clips to bridge mucosa to mucosa. So that's what I want to show you. So here is a Microtech clip, right? This is not even reaching to the other side, but we try to get there as much as possible. And the most important thing is to see if I can. So you can see that the first clip and second clip, there's quite a bit of distance. And then again, between the second and third clip, there's going to be some distance. One problem that I find with the Microtech clip is the rotation is not perfect. You can't rotate 1 degree by 1 degree. So you have to play with whatever you have. So we put those two clips, right? And then we put the third clip between the first and second clip, trying to reduce the size. So I like the Microtech clip because it is quite sturdy in its closure, but the problem is it doesn't rotate the way I want it to rotate. So you can see that, right? So now you can see that we put clip one edge and then we left a gap, another one here, left a gap, and another one here with gap. By doing this, we did basically not edge to edge, but inside the submucosa. So by this, we reduce the space from the mucosal edge to the mucosal edge. So once you do that, you can actually consider closing the defect. The other thing is there is another technique called almost like a double breast technique, where you can put one clip from the mucosa halfway to the submucosa. And then another clip from here halfway to the submucosa, another clip from here to halfway to submucosa. What happens is you're bringing the mucosa halfway across, and then use the second set of clips to bring the mucosa from the other side to this side. So that's another technique that you can play with. I just wanted to share the thoughts so that when you have a large defect like this, you can use that technique. So now, once I do this clips like this, then my next choice of clips is a resolution clip. The reason I prefer resolution clip is because of their fine rotation. It's probably one of the most amazing things with the clip is you can move 1 degree by 1 degree when you rotate. And that would allow you to go in between the defects. And then you can see that my cap is here and I'm going to the front side of the defect and then using the cap to anchor the clips and then pull back. And then I'm rotating my clip to the perfect angle that I want and then try to get in between those two clips. Right. So what I did was I basically did not edit this video. I wanted to let it play so that you can see whatever struggle I had to go through to close this defect. And I didn't want to make it easy or look it easy because I wanted to show what all went on in this closure. So I come back again and then small movements, open the clip, pull back, and then try to get the in between those two clips and then deploy the clip. So you go back and do the same thing. Now I thought, okay, why don't I close this defect, because it looks easier to close here. So again, use the resolution clip to close it. And then go back again. You can see that now, almost mucosa to mucosa closure. That is on the cecal side of the cecal polyp. And now come back. And then you want to have very fine movement. And one thing that I want to share with the fellows is, if you want to do EMR, you can easily do that as long as you learn how to control the scope tip. And if you can control your scope tip, you can do a lot of stuff. And you can learn that every time you do a colonoscopy. And don't think it's just another screening colonoscopy, but take pride in doing a very good exam with fine control of your scope tip. So you can see that we're able to close the defect quite a bit, partly because we made the defect smaller, and now we're trying to go from the anal side of the defect.
That's a good question.
So, go ahead.
If I were doing notes, which is a big hole, I would put a clip on both sides and use an endo loop to put them to the sides together, and then I could clip it all up. Why don't you do something like that?
So you could do that. The problem is that Dr. Graham, his access to this wound was a little bit difficult on the proximal side. If it is relatively flat and you can get it emphasized, it is much easier to do that. That is a technique that people have tried, putting clips around, putting a loop, and then trying to close the loop. That is a technique people have described. People can do that. I felt that I've closed quite a few of these large defects by using this technique of making the wound smaller and then closing it with the initial set of clips in the submucosa and the second set of clips from mucosa to mucosa. The other thing that people have described is, take a suturing device and go up to the right colon and then close it. But that is it's almost like a surgeon doing that. I don't know how to do that.
With your closure, looks inelegant.
I'm not perfect, sir.
Well, see, all I know is the papers I help write, and they are all notes people, so they just put clip, loop,
right,
and then close it down, and then use clips to finish it up. So it seemed like to me that grabbing it, the first one loop would bring it all together, and then you just clip it up. I don't know if I don't do any of this, but
right. So actually, that actually works much easier in the stomach. Because you have a relatively easy access, straightforward. While in the colon, what you have to do is you probably have to have a loop coming out of one channel of the scope and a clip coming out through the second channel of the scope.
Yeah, I think they do use double channel scopes.
Right. So you can see that, if you can use this technique and then close it. I just wanted to show it as a principle for people to consider if they want to use a technique to close a large defect. This person has done well. He didn't have any delayed bleeding. I don't know whether he didn't have delayed bleeding because he was not supposed to, or whether the clips helped. Only God only knows. All right, any comments?
Beautiful job, Raju. I know with our colleague that does ESD, they really leave their very large defects open. It's just not even possible to clip them closed. And I think this polyp was very illustrative in a couple of different ways. First, when we examined the polyp, we kind of could have underestimated the size and the shape of the polyp and the location. And then taking the time, you demonstrated that it was much larger than we thought. And then after we removed it, we thought possibly not possible to close it. And you showed that by doing those submucosal kind of clips, you made the defect, instead of being wide, you made it taller. It kind of pinched it up and made it into little hills. And then that way it was easier to place the rest of the clip. So I think this was a very beautiful case that illustrated a lot of good teaching points for EMR. Thank you.
Dr. Raj, a couple of questions.
Go ahead.
One, the settings for when you use the soft coagulation using the snare, is it like the similar soft coag settings that you use for the hemograsper?
Yeah, I basically don't change it. You know, to me, the way I look at it is soft coagulation of the edges. You know, you think about it in this way, right? What are we trying to do, right? We're trying to ablate tissue, right? And to destroy the cells. And the destruction of the cells should go deep into the mucosa, right? If it is just a little bit of whitening superficially, and you leave cells deep in the crypts, the polyp is likely to come back, right? It's just thinking through what we know, right? And I feel that it's better to create like a brown effect, right? It's almost like a well-done meat that is going to create a lot more deep destruction. And that's what will actually be most effective. So whatever you do, you want to see that it's not just a faint white, but you want to get a little more deeper thermal injury. And when you have a lot of fluid in the submucosa, your injury is not going to go deep, into the deep submucosa. So that's in terms of the settings, I just use 80 watts effect 4 soft coagulation. But you have to keep in mind, right? It's not just the wattage that you use or the effect that you use. It is also the duration of the current that you apply. And that's where that is where you control the total effect. And that's you gather by just doing it and with experience, right? How long are you going to tap on that pedal? Unfortunately, there's no way to teach that except seeing the effect. Each tap is just a tap. It's the same thing with forced coagulation APC. I'm just doing just a tap, and that small tap is creating a nice brown effect. Yeah.
Second question regarding the microtech clips on the submucosa. You prefer microtech because of the wide diameter? And can you also do that kind of submucosal to mucosa clipping with the resolution clip or the endo clip and the Cook clip?
You could do that. The only reason I felt that I wanted to use a microtech in this case, because among the large diameter, in terms of the wingspan of the clip that has the longest wingspan right now, I don't have resolution clips with the 17 millimeter wingspan. The other thing is to keep in mind is the microtech make is slightly different from the resolution clip. And sometimes when I'm trying to bridge a large defect, right, I'm pushing. I've had the problem where the hinge of the resolution clip has actually bent back. And you can't deploy the clip, and you have a clip that doesn't close, and it actually stays open like a T-shape. And when it happened, I had to basically come out with that clip in a net or something, rather than leave that T-shaped barbs, because that's going to cause some problems coming down. So given that a couple of experiences, I felt that, okay, why not use the clip that is a little more robust. Although knowing that I don't have a finer control, but in the initial stages of clip closure, you don't need that final control. But in the later stages where you saw I'm going in between the two clips, you know, and trying to close that small gap, I couldn't do that with the MicroTech clip. The only clip that actually works for me in terms of finer control is a resolution clip. And the other thing is also you have to keep in mind, I want to show you something else. This is a MicroTech clip, right? You see that, right? You see that, right? And then the MicroTech clip has a very short stem. And the resolution clip has a longer stem. And you could use this length of your clip, the stem of the clip, to your advantage. If you are closing a defect very close to the dentate line, I don't want a longer stem to poke on the dentate line, then I use a MicroTech clip. And if I want to use a clip stem to pull back the wound, right? Then I want a longer stem that I can put my scope to the front of it. And as I come back, this stem can redirect this wound for me to put my next clip. And I actually told Boston Scientific that, hey, your longer clip has an advantage. That is, you're able to close the defect much better because the longer stem helps you to pull the defect in whichever direction you want by using the cap of your scope. So does it make sense?
Definitely.
Right. Yeah, the other thing is, a lot of times, we all use what is available in the lab. And I personally, we have only these two clips. That's what we use. So although this defect is just above the ileocecal valve, which we could say that there is no need to put a tattoo. I thought that I should just leave a tattoo because this is an area that I struggle to find. And I was probably tired so to create a submucosal saline bleb. So you can see a little bit of messed up work there. So any other questions? And I wanted to show the pathology of this lesion because it caught me off guard, and unfortunately we couldn't get the slides last week to review. The pathology was, I believe it is a tubular villus with high-grade dysplasia, and there were 2 glands of cancer cells going into the submucosa, and just a couple of glands that the pathologist describes. And the margin is clear, there's no lymphovascular invasion, and whatever glands, they look like moderately differentiated. And I'll get those pictures next time so that we could look at it before we go to the next case. And right now, I feel that if you read the original paper by Christopher Williams from London, who wrote the original paper on large polyp resections, I think that came in gut in the 70s or 80s, large series. And he felt that although the pathologists describe whatever they describe in terms of the margin, if your defect looks clean, and then when he followed those patients, none of them had any recurrence. That's an interesting observation because right now we go by this 1,000 micrometers as one of the parameters, right? If it is less than 1,000 micrometers, then the chances of lymph node invasion are high, so we send them to surgery. But this gentleman, given his chronic kidney disease and other issues, I don't know what my surgical colleagues will tell me, but he is being seen by surgeons. And you know that he also has this large duodenal adenoma, circumferential duodenal adenoma. So I would leave it there, and if there are any questions, we can talk about it, or any comments.
Maybe if the patient will undergo genetic diagnosis, it would be interesting to know whether he has an underlying polyposis syndrome, right, because of the simultaneous presence of a large duodenal adenoma, cumulative more than 10 colorectal polyps, and these two laterally spreading tumors. It's a nice case to understand what's the reason to have this pathology.
Right. Actually, it's very interesting. When I resected this lesion, given the fact that it lifted very nicely, it was a granular tumor, quite uniform, LST granular. I told the patient that, that this is going to come back benign. So, all right.
Raju?
Yeah.
Sriram has some comments in the chat. I don't know if you want to look at that.
Yeah, I actually read that, it's good.
Oh, okay.
Yeah.
Okay.
Yeah. So Jaydesh,
can you
yeah,
go ahead.
How do you keep your scope straight during insertion? I don't know where Jaydesh is. If Jaydesh is in the US, you come over to MD Anderson, I'll show it to you. No, I mean that because it's very interesting. You can actually set up a camera outside in the room and try to do that. Unfortunately, I don't have that set up, and it's not easy to, although that's the ideal way to teach, right? You have a camera on the outside, you have that is in sync with the camera that's the monitor. That is ideal to teach. We don't have that set up to teach.
Haha, Raju, Jaydesh is in Singapore, but I'm sure he appreciates the offer. He would love to come, I'm sure. So how about the scope guide, Raju? How about that? That comes with the Olympus scopes.
Yeah,
you can put that thing on. They taught us about it, and then I personally never used it. But do you feel like that would be educational for fellows to be able to see that? The movements of the scope on the scope guide?
Yeah, now that you're starting the program, maybe you can request that. You have a lot of clout to do that.
Yeah, well, okay. Anyway, no, but we have scope guide though. We have it I think in all of our rooms.
We don't have that.
We don't have it in all of our rooms. Okay.
No, they took it off.
Oh, I didn't know that. Okay.
Not part of the new, when they came
contract?
Up with the new contract, they took them away.
Uh-huh. I didn't even realize that, Raju. I just assumed that it was sitting behind me on the processor. Yeah, so it looks like Joseph has been very curious about that too. But I think that would be helpful.
Yeah, I personally think that, we do all these things. To be honest with you, I think the most important thing that we should focus on for people to learn, how do you go to the CCOM, and how do you come out of the CCOM and do a good exam? And that is the most basic thing on which you can build everything else. And
right.
I wish there's a way to do that. We need to think about it for sure.
I think cameras, at least in a limited way, out within the procedure room, directed away from the patient, of course, but looking at the endoscopist's hand movements, posture, technician assistance, all of that kind of stuff, I think would be very educational for people. Right. And even for ourselves, right? Because we all want to have nice long careers doing endoscopy, and, finding posture and ergonomic interventions that we can do to help each other, I think would be a wonderful service, because, we need to have the physicians to take care of the patients, and we have to take care of each other. So
I think, last week I shared that book called 168 Hours. If you guys have not had a chance to read, make sure you read. And one of the big lessons that I took away from that book is there are certain things that are not negotiable. And one thing that is not negotiable is taking care of yourself. That means taking care of yourself by putting in the exercise you need to put in.
Thanks a lot. Thanks a lot. Bye-bye.
And there's more time than you think to do that. All right, thank you so much. If there are no other questions, we'll finish this session. I really appreciate you joining. Dr. Grant, thank you so much, sir. Thank you. Sylvia, thank you.
Thanks a lot.
Sylvia, thank you.
Thanks, everyone. Okay, bye, Raju. Bye, everybody.
Bye.
Have a good week.
Aman, thank you so much.
Thank you. Thank you so much.